Good day. Today's presentation is entitled Medication Reconciliation in Our Patients' Stories. By way of introduction, a typical 300-bed acute care community hospital in the United States will admit about 15,000 inpatients per year. Each of these inpatients will receive, on average, 10 different prescription medications per day, and the physicians in the facility will prescribe, on average, over 1,000 new medications per day. The pharmacy department of the hospital will stock maybe between 1,500 and 2,000 medication, but this is a fraction of the over 10,000 different medications that are available for use in the United States. Today's presentation is designed to provide important insight and information about our patient stories as it relates to the practice of medication reconciliation. My name is Dr. Christopher Keys. I'm a practicing clinical pharmacist, health services researcher, and educator, and am actively involved in the development of best practices in medication reconciliation, and I will be your presenter for today. The objectives of today's presentation include the following: to highlight medication reconciliation as a practice and an essential element of safe and cost-effective care of our patients, to recognize the physician's role and the integrated healthcare team's role in the provision of medication reconciliation, and to emphasize the resources of a health facility and the competency of its practitioners to successfully perform medication reconciliation. Our presentation is set in an acute care hospital with an emergency department, and we do have an entire healthcare team involved in this process. We have the attending physician, the hospitalist, another LIP, specifically a physician assistant. We have the nurse, the clinical pharmacist, the unit secretary, and our patient stories takes place on a Saturday shift in 2012. Medication reconciliation occurs at all transitions in care. These include when the patient transitions between prescribers, between levels of care, and between healthcare settings. Also important is that medication reconciliation has 5 major steps. These major steps include the development of a current medication list of the patient that the patient's taking or receiving, as well as the allergy history. It involves the development of a list of medications that need to be prescribed, so let's say as in a hospital admission. It involves the comparing of the list on admission with the medication the patients previously took. Then there needs to be a clinical judgment about the appropriateness of the 2 lists. And the last phase involves educating other healthcare providers as well as the patient about the new medications that are being prescribed. Let's discuss our first patient. We refer to the patient as BB. She has been in the hospital for 12 days on the behavioral health unit. It is at the time of discharge that her 9 treatments, along with her outpatient prescriptions, are forwarded from the unit to the pharmacist for final review and preparation of the final discharge medication list. It is during this review by the pharmacist that is identified that there is a breakdown in the medication reconciliation. The outpatient prescription for Ativan is ordered at 2.5 milligrams PO BID as needed for anxiety. This is different than the inpatient regimen the patient was receiving, which was Ativan 0.25 milligrams PO BID as needed for anxiety. So the system breakdown occurred at the point of prescribing. How did it break down? Probably related to a transcription error on the part of the physician. This is often seen as the most common type of discharge medication reconciliation error in clinical settings. It is important to note that Ativan, if it had been given at 2.5 milligrams, the patient may have experienced severe CNS depression and respiratory depression and may have required rehospitalization. The resolution occurred when the pharmacist contacted the physician. The prescription was corrected, the discharge med list was corrected, and the patient was sent home with accurate information on both discharge list and prescription. Let's review our second patient. This patient was seen in the emergency room of our hospital. It was brought to our attention by the hospitalist who was admitting the patient that their emergency department records revealed that they were receiving COUMADIN. It was the physician who noted that based on their assessment, COUMADIN was not part of the active medication history and sought from the director of pharmacy and the nurse manager clarification as to how the information appeared on the electronic health record in the emergency department. The physician's assessment is that the patient had been most recently placed on XARELTO or rivaroxaban, which is oral anticoagulant, for their treatment of their atrial fibrillation. Consequently, the physician initiated the XARELTO on the inpatient admission orders and did not continue the COUMADIN. On further review by the nurse manager and the pharmacy director, it was identified that the breakdown point in the medication reconciliation on admission occurred because a 2-month-old medication history from a previous admission was used and represented as the current medication list on admission. Apparently, the nurse had not updated or verified the 2-month-old medication list when it was entered as current meds for the patient. This is a very common area of concern for medication reconciliation on admission, the use of old, outdated medication lists, and should be avoided whenever possible. This patient, had they received XARELTO and COUMADIN, may have experienced a severe or life-threatening bleed, and it's fortunate that the physician both identified this in their medication reconciliation practice, as well as brought it to the attention of the managers so that the system problems could be identified and addressed. Let's shine a spotlight on medication reconciliation from the perspective of how it's observed around the nation. Based on published research and U.S. government reports, patients are at their greatest risk of harm from medication during transitions in care. The Joint Commission's 2006 National Patient Safety Goal established that medication reconciliation is a vital aspect of patient safety in healthcare settings. Medication reconciliation is supported by all major governmental accreditation and professional organizations in the United States. We've been speaking about medication reconciliation, but let's just take a look at one definition which is fairly all-encompassing. It's provided by the two leading pharmacy associations in the United States, ASHP and APhA. They define medication reconciliation as a comprehensive evaluation of patients' medication regimen at any time there is a change in therapy in an effort to avoid medication errors, as well as observe compliance and adherence patterns. It should occur during every transition in care. It should be patient-centered, and it should be standardized across the healthcare continuum. Let's look at a third story. In 2012, as part of an IRB-approved research study in a community hospital, it was observed in the emergency department that of over 400 patients admitted within that time period, there were 65 suspected adverse drug events. I bring this research study up because it identifies an important observation that's seen in other reports. Of the 65 patients with a suspected adverse drug event, 8 of those patients may have experienced an adverse drug event causing hospitalization for which a medication was the cause, yet the medication had not been identified at the time of admission during the medication reconciliation process. Let's look specifically at the types of adverse events that occurred in those 8 patients. You see small bowel obstruction associated with the use of an opiate, in this case fentanyl, gastrointestinal bleeding associated with the use of an anticoagulant, Lovenox, a subdural hematoma associated with the use of a combination antiplatelet drug, Agranox, and secondary to the use of several different non-steroidal anti-inflammatory drugs with or without antihypertensives, we see several cases of patients with acute renal failure. Our final story is a description of what happens when medication reconciliation is only partially effective or where it fails to be effective. Our patient is Barbara. She's a 63-year-old female who was admitted for a total hip replacement. It was noted after surgery that the patient was very drowsy but arousable. In post-op day 1, the patient became confused and developed visual and auditory hallucinations, which prompted the nurse to move the patient to the nursing station, and the patient had to be restrained. It was at this time that the nurse manager in the post-op unit contacted the clinical pharmacist and asked them to review the 17 medication that the patient was receiving in the hospital. In addition, the attending physician consulted psychiatry to evaluate the patient's change in mental status, but this wasn't going to be done until the next day. Upon review of the case by the clinical pharmacist, it was noted that one of the 17 medications was benztropine, also known as Cogentin. The patient in the hospital had been receiving for the last 2 days 5 milligrams of Cogentin a day. On further investigation, the pharmacist noted the patient had received as an outpatient for approximately 1 year Cogentin, but at a dose of 0.5 milligrams per day. Apparently, the patient was receiving tenfold their outpatient dose while here in the hospital. It was at this point that the pharmacist consulted with the nurse and with the covering PA, and the Cogentin was placed on hold. The psychiatrist came in and evaluated the next day the patient and wrote for the medication to be held for 48 hours and then restarted. It was observed that the patient's change in mental status, their hallucinations resolved within 36 hours, and the patient was stable again. It is important to note that this patient had a history of behavioral disorders, had a history that required Cogentin use to reduce extrapyramidal reactions associated with their antipsychotic medication, but had been stable prior to admission and been stable before surgery. What was the medication reconciliation breakdown? It was a prescribing error that in fact had gotten through the entire system. It had bypassed 2 PAs, the nurse, the clinical pharmacist, and it had gotten to the patient. It is important to note that in Barbara's case, the last phase of the medication management, which has to do really with monitoring of patients and patient education, was the point at which it was identified that a medication error had occurred, and early detection of the problem and resolution by holding the medication went a long way to probably preventing the patient from having a more advanced or complicated hospitalization course. Let us shine a spotlight on an important aspect of medication reconciliation, which is that of tools and resources that we use in clinical practice. Specifically, let's be aware that there are powerful, real-time, national outpatient prescription databases that are available that derive outpatient prescription records from the doctor's office when they e-prescribe, from the pharmacies that dispense in a retail setting or a mail order setting, and even from hospitals in some cases. It is with the use of databases that I just described that the pharmacist was able to identify that the patient in our prior story was receiving 0.5 milligrams of Cogentin rather than the erroneous 5 milligrams that was being given in the hospital. For our part, we should continue to utilize these types of resources and incorporate new technologies, but do so understanding the strengths and limitations of the technology as it relates to the delivery of care to our patients. In closing, whether you are involved in electronic health records or manual record review, it is important that we continue to share the stories of our patients and the impact of medication reconciliation among each other, as well as within our organizations, as we continue to strive for excellence in the care of our patients one at a time. thank you for your participation in this educational initiative.